Ahmedabad. He is interventional cardiologist at Epic Hospital. Therefore, you will see that it is so today the case scenario is that if I have a real patient, hypertension with the hypertension retinopathy, the blood pressure is 152 by 98 control on the Ramipril 10 mg with 105 mg and Chlorthalidone 6.27 per day. The creatinine is 1.6 milligram percentage with eGFR is less than 60, 55 ml per kg per 1.73 meter square. Means this is stage 3A CKD. The patient heart rate is around 90 blood pressure, beats per minute. So basically, the patient is having an uncontrolled hypertension on the first line drugs with the CKD presentation with higher heart rate. So what is the next? Either adding the beta blocker or adding the alpha blocker or newer CCD, AC inhibitor or ARB. In this case, I will prefer the adding the beta blocker. I will say why. In the background of the CKD in India, in the today data, the 1.18 million CKD disease case is reported in India. Out of that, around the 2 lakh new patients develop the kidney failure each year. Around 1.75 lakh patients receiving the chronic dialysis per year. What is the CKD pathophysiology? Here there is an abnormal sympathetic system in the CKD which lead to the basically increase the sympathetic activity, which ultimately lead to the functional and structural alteration in the heart artery and kidney, which lead to the fatal and non-fatal CV event. The second mechanism is increase the RAS activity and angiotensin II level, which ultimately lead to the increase in norepinephrine release and ultimately lead to the fatal and non-fatal CV event. So basically, angiotensin II and sympathetic activity become the detrimental for both kidneys. Chronic sympathetic excitation is a major contributor to increase the CV risk and mortality in CKD patient. In the CKD, because of the sympathetic overdrive, the patient having the high blood pressure lead to the consequences, the vascular consequences at the heart level. It lead to the increase the event of heart failure, ischemia, arrhythmia, and increase in the LVH at the arterial level. It increase lead to the vasoconstriction, increase in the case of atherosclerosis, and decrease in the arterial compliance. At the kidney level, it ultimately lead to the sodium retention, hypervolemia, proteinuria, glomerulosclerosis, and increase in the RAS activation. In the CKD, because of the sympathetic activation, the patient having the resistance hypertension, it lead to the at the heart level increase the LV remodeling, increase in the risk of heart failure, atrial remodeling, increase the risk of arrhythmia, increase in the heart rate, increase the O2 consumption, and increase the rate of ischemia. At the arterial level, it ultimately lead to the increase the wall thickness, decrease the distensibility. And as we know, in the kidney level, it increase the sodium retention and increase the renal blood flow. So, as in this slide, as we see that if the CKD stage is increased, there is proportional increase in the risk of atherosclerotic CVD risk and increase in the risk of non-atherosclerotic CVD risk. In atherosclerotic CVD event, it includes the CAD, ischemic stroke, and peripheral artery disease. Whereas in the non-atherosclerotic CVD, it includes the LVH, arrhythmia, sudden cardiac death, arterial calcification, valvular calcification, hemorrhagic strokes, and other complications. So basically, the interrelation between the CVD risk factor and CKD, as we know, the cardiovascular traditional risk factor, some are CKD related risk factor for cardiovascular risk factors like the anemia, metabolic, mineral metabolic disorders, albuminuria, inflammation, hyperthyroidism, hyperhomocystinemia, oxidative stress, and malnutrition. will ultimately lead to the atherosclerosis, which ultimately lead to the ischemic complication, increase the cardiovascular disease, ultimately to heart failure, increase the left ventricular hypertrophy, lead to the systolic and or diastolic dysfunction, lead to the cardiomyopathy. These three combined complications lead to the increase in the cardiovascular event and increase in the mortality. Here comes the role of beta blocker for coronary heart disease in chronic kidney disease. The scientific evidence supports the sympathetic power activity is an important contributor of CKD in patient with CKD. The high prevalence and case fatality rate of CVD in the CKD patient argue for use of cardioprotective medication, especially the beta blocker in this patient. Beta blocker significantly reduce the incidence of cardiovascular endpoint in high-risk patients with CKD irrespective of kidney function. So here the point to remember, the beta blocker reduce the sympathetic overactivity, decrease the rate of mortality, decrease the event hospitalization, decrease the rate of hospitalization. In the choice of beta blocker, there is a classification of the beta blocker according to their beta 1 selectivity with intrinsic sympathomagnetic activity and without intrinsic sympathomagnetic activity. Here we are commonly used the four beta blocker commonly used are the carvedilol, metoprolol, bisoprolol, and nebivolol. Although nebivolol is often characterized as a B1 selective beta blocker without intrinsic sympathomagnetic activity, the stimulation of cardiac and endothelial B3 receptor by nebivolol, which is ISA, is associated with the nitric oxide release. This agonism at the beta 3 receptor lead to the vasodilatation and has a negative inotropic effect in the myocardium. So the commonly and currently used beta blocker, out of 4, the nebivolol has no strong outcome data across the disease in patient on hemodialysis. So the 3 options left, like bisoprolol, carvedilol, and metoprolol. The comparison between the carvedilol and metoprolol and mortality in maintenance hemodialysis, the carvedilol show the superiority over the metoprolol in this hemodialysis patient. So, in conclusion, related to the metoprolol initiation, carvedilol initiation was associated with higher 1 year all-cause and cardiovascular mortality. One potential mechanism for this finding may be to increase the occurrence of intradialytic hypertension after the carvedilol initiation. So, according to the diacetyl, some beta blocker like the atenolol, acebutolol, and metoprolol high dialysis group, while the bisoprolol and propranolol is including the low diacetyl group. While comparing these both group, the low diacetyl beta blocker are associated with higher rate of mortality in patients older than the age of 63 years receiving the long-term hemodialysis. So, bisoprolol has a better outcome as compared to the metoprolol. In summary, the interconnection exists between the CVD and CKD. The sympathetic overactivity is a part of both CVD and CKD. Beta blocker should be utilized in patients with CVD and CKD. Beta blocker therapy has been documented to be effective even with moderately or moderately severe renal dysfunction in patients on hemodialysis. Carvedilol may cause intradialytic hypertension and increase the rate of mortality. So, in patients receiving the long-term dialysis, bisoprolol can be preferred due to its better beta 1 selectivity and better outcome compared to the other beta blocker. So, my choice would be a beta blocker, and it is a bisoprolol in this case. Thank you.
Good afternoon to all the colleagues, seniors and juniors. My topic and my message for today afternoon is loud and very clear. That is, alpha blockers are the anti-hypertensive drugs of choice beyond the first-line agents. So I have been given just 10 minutes, but I think I'll complete before that. I need just 6 points to say my point that alpha blockers are indeed the drugs of choice beyond the first lines in hypertensive patients. Let us start with the recommendations. Most of the international societies like the ESC, ACC, ISH, they recommend that you grade the hypertension of the patient according to their systolic and diastolic blood pressure readings. And if you have uncontrolled hypertension in the form of resistant hypertension or resistance to treat hypertension by a physician, We need to do ABPM to classify in which category the patient belongs. Also, we now understand that it is not only the grading of the hypertension, you have to classify the patients into low risk, moderate risk, high risk, or very high risk, depending upon the other CV diseases the patient has, or the risk factors the patient has, or hypertension-related organ damage the patient has. Also, we understand that hypertension, the treatment of hypertension has been streamlined depending upon various subgroups of patient, and more or less it is similar. We start with a combination therapy, which can be a ACE-ARB with the CCB, or it can be a ACE-ARB with the diuretic. If the blood pressure is not controlled, we combine these three classes, and if still the blood pressure is not controlled with what we call a resistant or uncontrolled hypertension, we add on either alpha blocker, a beta blocker, or a spironolactone. Beta blockers have very few selected indications, which we'll be discussing in the near slides. So what is our patient? Our patient is a 55-year-old male. He's having grade 3 of CKD. His ambulatory blood pressure was done because he was uncontrolled, and it found that the mean pressure was in fact more than 150 or 90. He was already on the 3 first-line drugs, and I believe that they were given in their maximum tolerated dose, because that was what was mentioned. So he was on ACE inhibitor, he was on CCB, he was on diuretic. His heart rate was around 90. The electrolytes we don't know. So just to summarize, my patient was stage 2 hypertensive patient with hypertension-related organ damage in the form of CKD with a moderate CV risk. This was what our patient is. And he doesn't have any heart failure, he does not have any angina, he's not a post-MI patient, he's not having any tachyarrhythmias. So what does our patient needs? I think the answer is clear. Now patient needs alpha blocker. Why? Now the newer alpha blockers, these are long-acting preparations, the GIST preparations, they are very long-acting, they have a uniform action, better pharmacokinetic and pharmacodynamic profile. The postal hypertension incidence has decreased. The blood pressure is uniformly lowered throughout the 24-hour period. The nocturnal dip is in fact preserved with alpha blockers. There is reduction in the heart rate as well. And there have been no increased incidence of heart failure apart from the ALHUT trial, which we'll also discuss in this few slides. Also, there are very potent beneficial pleiotropic effects of alpha blockers, which are not seen with other second-line and third-line antihypertensive agents. And this includes a favorable metabolic and dyslipidemic profile. It decreases the total and LDL cholesterol and increases HDL. Also, there is improved insulin sensitivity, there is improved endothelial function, and there is recovery of spontaneous reflex sensitivity. So how do I say this? There are a lot of data to support this. We have the Associate trial, the ASCOT, the PLA, and the TORMENTOS trial, by which I presented this data. Now, why not a newer CCP or a newer ARB or newer ACE inhibitor? Our patient can just switch over to the next CCP, or add on a newer ARB, change the previous ARB. Well, when you see the hypertension guidelines and the various trials, as a stipulation, you should be able to read between the lines. In any uncontrolled hypertension without CV risk factors, if your patient is low to moderate risk, none of the trials of hypertension have shown morbidity or mortality reduction with ACE inhibitors or ARB. We have the HOPE, the CAMLET, the ALHUT. They clearly say that if your patient is on ARB, just changing the class of ARB in uncontrolled hypertension doesn't affect the morbidity and mortality. It might reduce the blood pressure to a more or little extent. And this is, again, supported by the CAMLET study, the ASCOT BPLA, and the ALHUT trial. CCPs, I would say neither worse nor better, but remember, CCPs as a class, they increase the adrenaline stimulation, and that can theoretically and practically increase the ischemic events. Also, I would like to emphasize in non-diabetic hypertensive CKDs with proteinuria, CCPs, they are worse, they worsen the renal function. So again, the data is supported by the NODEL and the ARS trial. Why not beta blockers? Just add beta blocker in this question. Well, again, if you see in just uncontrolled hypertension without any CV disease like MI, heart failure, beta blocker have not shown any decrease or difference in fatal, non-fatal cardiovascular events or stroke or all-cause death. In fact, I would say that there are certain papers, there have been certain studies which have shown increase in mortality and new incident diabetes in patients who have been put on beta blocker as an anti-hypertensive. Remember, so this is what has to be understood from the various trials that have undergone. Choosing a drug depends upon the patient, a particular patient. So you need to understand whether that patient fits into a particular trial and not take the data from the trial to treat a particular patient. So again, the Escort PPLA trial and the LIFE trial have shown the same. Also, the guidelines, if you see, they clearly say when the blood pressure is not controlled by the first line drugs, it's either alpha blocker, spironolactone, or beta blocker. I have patient, we don't know the electrolytes, he was a stage 3 CKD. As far as beta blockers are concerned, the indications are very clear. These patients need to have some sort of cardiovascular disease, which might be, say, MI, angina, heart failure, atrial fibrillation, might be a woman, or she might be pregnant. Our patient certainly is not pregnant. Now, for Indians, yes, there is no data so as to say which antihypertensive to be chosen after the first 3-line drugs. Well, at this point, I would just emphasize the ALHET trial. The ALHET trial was a trial after which alpha blocker almost got delisted. Initially, 20 or 30 years back, alpha blockers was one of the first-line drugs to treat hypertension, but after ALHET, it was just blacklisted. But need to see what ALHET actually meant. If you go deeper, ALHET trial showed that use of alpha blockers was associated with increased incidence of heart failure. I would like to say here that all those patients who were included in the ALHET trial, the ejection fraction, the BNP were never measured prior to the inclusion. Secondly, the heart failure assessment in the trial was done by a physician by some shift criteria, and a cardiologist was never consulted compulsorily, or echo was not done compulsory to say that the patient was having heart failure. Asians, or in fact Southeast Asians, were never included in this trial. At that time, longer acting preparations, the GIST preparations of alpha blockers were not available. Short acting preparations were used, which ultimately had more side effects. Finally, despite the fact that ALHET showed that there is increased incidence of heart failure, there was never an increase in mortality with prazosin. Despite that fact, prazosin was off list after this trial. Finally, cost. I think we all know prazosin is a DPCO molecule. So the cost of prazosin is quite low. While the newer beta blockers, as we say, bisoprolol is not in DPCO, so are the newer CCBs like cinlidipine or zenlidipine, or say newer AC inhibitors or ARBs for that matter as well. Sartan, they are also not included in DPCO, so their cost is certainly higher. We do understand the average Indian income to be around 10,000, say. For those patients who are treating themselves and their other family members, I still believe we should choose drugs which are in DPCO so that they are available to them. So just to conclude, I would agree that alpha blockers have been superseded by AC inhibitors, ARBs, CCBs, and diuretics as the first choice. Yes, that's correct. The first choice is never an alpha blocker. But if the first line has been exhausted, which is exhausted in almost 2/3 of the patients, which majority of the registries have shown, we need to add some. And add-on therapy, as I said, is usually indicated in most of the patients in their natural history of hypertension. Alpha blockers certainly is a definite choice in this setting. Thank you.
So friends, just recapitulate: 55-year-old male, heart rate is 90, grade 1 hypertensive retinopathy, blood pressure 152/98 by ABPM, very well managed by whoever was managing, and he was on Ramipril 10, Chlorthalidone 6.25, and amlodipine 5. Creatinine is 1.6, eGFR is 55. What is the next best strategy? Well, friend, let me tell you, there is no single best strategy. None of my friends who have presented the data is wrong, but I would present what I feel is good. So, according to me, changing to a newer calcium channel blocker and ARB, optimizing the dose of diuretic would be a better strategy. Let's just understand what's there on our plate. He has an uncontrolled hypertension. It's not resistant hypertension. It's only when resistant hypertension is there, you need to look for the fourth drug. We have not used all the armamentarium we had. All right, nuclear need not be brought out. We have enough of tanks and other things if we are going to Ukraine. So I think we have enough there. Resistant hypertension is you use 3 drugs, renally adjusted, optimal dose of all antihypertensive agent, including an optimal diuretic, then you have a resistant hypertension. He has a higher sympathetic tone, but is beta blocker the best choice? Probably no. I think Dr. Chaudhary has already been effectively countered by the second speaker. So I don't need to say much against the beta blocker, but he does have a sympathetic higher tone, and I do agree it needs to be addressed to. And he does not have heart failure, angina, myocardial infarction also has been emphasized. He is just 55. He is relatively young. He has a long stint to go. Even a shade of difference we make in his cardiovascular surrogate endpoints also, it's likely to lead to much better cardiovascular outcome in a long term. The worrisome factors here are CKD stage 3A and retinopathy. We don't have much data about potassium, uric acid, albumin, creatinine ratio, echo, ECG, diabetes, etc. We presume they are within range. And he is on 3 drugs, which is on suboptimal dose. What do the guidelines say? It is very clear in guideline over here that beta blocker, when it is to be used, my colleague Dr. Vishal has already mentioned about this thing, that he does not have any of those indications for beta blocker, and he is not on the optimal dose of diuretic calcium channel blocker. So to me, we are somewhere in this stage 1 and stage this is this first step and second step. We have not even reached the third step. So we need not take out more number of things. This is the uncontrolled hypertension we have. Uncontrolled hypertension is one of the biggest risk factor, I would say. If 75% of the people are not being optimally treated, majority of benefits which we have in the trials in terms of CV endpoint reduction are not going to be there at all. We don't need to look for other things. Control the blood pressure optimally and we'll have a lot of benefits. What are the reasons why they are not controlled? There are fourfold reasons. It could be patient related, physician related, the therapy related or disease related. Patient related factors, we need to find out whether his lifestyle is optimal or not and whether he is adherent to or not. And if he is not adherent, which most probably he is not, what are the reasons and how we can improve adherence? Improving adherence will give you the maximum incremental gain in terms of CV endpoint reduction. Therapeutic inertia by the physician is obviously apparent over here, and the strategies they leave a lot to be desired, and that's why the topic of debate today. And of course, patient has an advanced vascular disease. What does retinopathy say? Retinopathy clearly tells us that even among CKD patients, it tells us that patient has an incremental risk. He has an incremental risk for cardiovascular endpoints. So we need to be far more aggressive in this patient. My proposal in this is to step up the calcium channel blocker dose as well as variety from amlodipine 5 to equivalent of 10 milligram amlodipine, that is cilnidipine 20 milligram, change from Ramipril to telmisartan 80 milligram, and chlorthalidone dose to be increased to 12.5. I'm going to justify each stage. Why cilnidipine? Cilnidipine is L plus N channel blocker. What does N channel do? N channel increases the norepinephrine release from the presynaptic terminals. So it increases the local sympathetic activity into the tissue, as well as there is a spillover into the system. Norepinephrine levels are going up. Cilnidipine is going to block this release, so it will reduce the heart rate, because if the heart sympathetic activity goes down, that is where it matters. It reduces in the kidney. In the kidney, what happens? Afferent and efferent arterioles both are going to dilate. Intraglomerular pressure will come down. Glomerulosclerosis will come down. eGFR is going to increase. Protein excretion, albumin excretion, which is supposed to be an important surrogate marker both for kidney as well as for heart, it is going to come down. And other markers of renal parameters here, urine, OHDG and LFABP also is going to come down. All these things will culminate into restoration of podocin and nephrosin, and it will protect the podocyte. Now we say that it's all theory. What evidence do we have? In beta blockers, no significant evidence was shown. For alpha blocker also there is no direct evidence. Here we have at least some evidence. When you count on an average, there is a significant reduction in heart rate. Believe me, the first generation calcium channel blockers, nifedipine, etc., we are all aware about. Patient used to come with palpitation, tachycardia, pedal edema, etc. Here there is a first time we have an evidence that there is a significant reduction 24-hour, daytime, nighttime, both. And if you take high rate morning hypertension patients who have a high morning systolic blood pressure rise, high morning pulse rate rise, and we know the chronobiology of hypertension. Early morning risers have, despite all other parameters being equal, office blood pressure controlled and equal, despite that they have a higher incidence of cardiovascular endpoints. So chronobiology is important. In this morning riser group of patients where the resting heart rate was somewhere around 85, there was 9.7 beats per minute reduction in this trial, a very significant reduction. Pedal edema is another relatively minor side effect, relatively innocuous side effect, but it leads to drug discontinuation, and we all know drug discontinuation is not good for this group of patients. And we have enough number of small trial data which shows that pedal edema definitely comes down in cilnidipine. So what is there in theory, it's there in practice. Around 10-15% incidence with amlodipine drops down to around 2%. This is some data from Andhra. Again, it showed the same thing, that tachycardia comes down, increased heart rate comes down, everything comes down. Now, what about the proteinuria? Here you can see that for the equipotent dose of cilnidipine versus amlodipine, on the left side you can see the systolic diastolic blood pressure reduction was equivalent with both. Despite that, with amlodipine there was around 15% increase in urine albumin ACR ratio versus cilnidipine where there was a 15% reduction. So that is one evidence. We might think that do we have strong evidence? This is the meta-analysis published in 2022. Almost 11 trials, more than 500 patients. Creatinine did not change between the two, but urine protein creatinine ratio definitely dropped significantly. eGFR rose significantly in favor of cilnidipine versus amlodipine. And urine protein, we know, is a very, very important surrogate marker for cardiovascular endpoint as well as renal endpoints. So on top of equivalent blood pressure reduction, if we have some incremental benefit, it's definitely desirable. One patient is on Ramipril versus telmisartan equivalence we have already shown in many trials, but last 4 hours, again going back to the chronobiology, in last 4 to 6 hours, what happens to the blood pressure when patient is on Ramipril versus cilnidipine? And here you can see that both systolic as well as diastolic blood pressure in last 6 hours, the reduction at the end of 14 weeks with telmisartan was 14 versus Ramipril only 9. So we can have on an average 5 to 6 millimeter mercury difference. When it comes to Chlorthalidone, even in patients with CKD, there is a significant reduction in blood pressure when you use optimal dose. So in CKD, we say that loop diuretics are required, but even up to stage 4 CKD, the thiazide diuretics, they keep working, and urine protein creatinine ratio definitely comes down. So overall, considering overall evidence, they can definitely be used with preserved good efficacy in patients with CKD. So this was my contention. Amlodipine changed to cilnidipine 20 milligram. That will ensure optimal renoprotection, surrogate markers, reduction in reflex tachycardia, reduction in heart rate, reduction in sympathetic activity. Ramipril to telmisartan will improve the blood pressure control as well as chronobiology last 6 hours. Chlorthalidone definitely needs to go up to 12.5. Of course, it's a CKD patient, is going to require monitoring. After this are exhausted, still there is no role for beta blocker or alpha blocker. The fourth drug, as per the stepwise ESC, AHA, Indian guidelines, wherever you see, it is the spironolactone, because 25% of the resistant hypertension would come down under control with spironolactone. So friends, with that, I rest my case. Thank you very much.